Good evening, everybody, and thank to Professor Salvatore Di Somma for the kind introduction. I'm Dr. Marianna Nigro, and I'm part of the postgraduate school of emergency medicine in Rome, and I will be answering with my presentation to the question, is there a value of immediately detecting hemolysis in the emergency department for POCT blood gas analysis and eye-sensitive troponin assessment? So, laboratory errors are the main reason of delay laboratory response, and so difficulty in managing of patients in the emergency department. We know, in fact, that hemolysis is the most common pre-analytical error from a laboratory analysis, and also that the vast majority of hemolytic specimens come from the emergency department. So ENCHEC has developed this tool. There is a point-of-care system to detect immediately hemolysis in the emergency department. We designed a study that has three aims. The first one is to analyze the prevalence of hemolysis in blood gas, arterial blood gas samples and venous withdrawal in emergency department. The second aim was to do a method comparison between ENCHEC and our laboratory, and then to evaluate the influence that hemolysis has in the blood gas sampling, arterial or venous. This is our method of collecting samples. We had a target of 700 samples obtained in ED. We performed the arterial or venous withdrawal, and then analyzed with the sample with ENCHEC, and then send it to the laboratory or analyzed it with the POCT for blood gas analyzation, and then collect the data and also the action that the clinicians had taken after the response of an hemolytic specimen. So, we collected all the samples in three different emergency departments that are Sant'Eugenio, Sandro Pertini, and San Giovanni Addolorata in Rome in a period between 17th of March 2021 and 13th of April 2022. We collected 726 patients, 524 were arterial blood gas samples, and 202 were venous. We had to exclude, for statistical reasons, 140 samples, but we were able to analyze 384 samples from the arterial part, and we found that the 13% of them were hemolyzed. As well, for the venous part, we found that there is 14% of samples that were hemolyzed. These are our results for the arterial part. There is a large operator variance, of course, but we can see that potassium, calcium, and PO2 are impacted by hemolysis. In particular, we can see the distribution of potassium in the hemolyzed samples. This column that is in this graphic shows that the majority of the sampling, in the majority of the withdrawal, the potassium was in the range, but we know that potassium in hemolyzed samples is higher. So there is the strong possibility that in this in these patients, we could have found an hypopotassemia. So it can be crucial to identify hemolysis to avoid an incorrect therapeutical choice. These are our venous results. We can see that we have a lot of different triage symptoms, but for the hemolysis, neither triage symptoms or gender impacted significantly the presence of hemolysis. we have done also a comparison between the two methods, and we found that there is a moderate concordance between MCHEC and Central Lab in detection of hemolysis, and also that MCHEC has a 76% of sensitivity and a 93% of specificity. We found that LDH, potassium, and sodium are significantly impacted by hemolysis, not as much as troponin, but as we can see from this graphic, 14 patients had a significant value of troponin, but a lot of them stays in a gray area. We believe that we need more study to understand the real impact of troponin in this case, to do a correct rule-in and rule-out in case of a suspect of a myocardial infarction, because our database had a small sample. We know also that if hemolysis is found immediately in emergency department, it's potentially time-saving. In fact, hemolysis delayed the response from laboratory between 40 or 50 minutes. So, in conclusion, MCHEC is to be a useful tool for rapid detection of arterial and venous hemolyzed samples in AD. Using MCHEC, we can reduce the time of waiting for lab results. Obviously, the most impacted lab results was potassium, and with the use of POCT in blood gas analysis in AD, it is possible not to underestimate the presence of hypopotassemia in hemolyzed samples, and so to avoid incorrect therapeutical choices. Also, MCHEC seems to be able to detect immediately the presence of hemolysis for high-sensitive troponin evaluation, reducing the time and the necessity of further additional sampling in AD, accelerating rule-out and rule-in process in suspected acute coronary syndrome patients. Obviously, our study has some limitations, such as strong operator variance. Also, we missed to note the VO2 in the final questionnaire. There is absence of a control sample for the BGA after the hemolysis response. But most important, the venous samples are few for now. So we need more data, and further studies are needed. Thank you.
Thank you, Marianna. Now the presentation is open for discussion. Okay, if no one, I have a question for you. So I think that should be important for you when you use a point of care system in the emergency room, any kind of point of care, to detect the possibility that pre-analytical error is there. So you can speculate that this is something that, because if you send the samples in central lab, that's okay, you have no problem.
Yeah.
Could you please speculate on this?
Yeah, because, for example, in emergency department, we don't use a point of care that detect hemolysis for arterial samples. So it is important to have a tool that says that that sample is not available and could lead to an incorrect therapeutical choice. Because obviously, as Professor Di Somma was saying, in laboratory, when you send a sample in laboratory, you have not an immediate response, unfortunately, but you have the response that the sample was not available, was not good for analyzing.
Thank you again.